Good afternoon and welcome everyone. Thank you all for joining us today. My name is Bianca Clark and I am the Partner Health Improvement Coordinator with the Michigan Department of Health and Human Services. Today, once I get my screen moved, today we are going to be talking about applying best practices for expedited partner therapy within emergency departments, pharmacies, and state health departments. Again, I am the Partner Health Improvement Coordinator with the Michigan Department of Health and Human Services within the Bureau of HIV and STI programs. And within my position, I help to spread awareness about sexually transmitted infections. I help to spread awareness about traditional and internet partner services and also expedited partner therapy. So in today's webinar, we will be discussing the utilization of expedited partner therapy initiatives and best practices. We will also explore some of the strategies and partnerships that we, the Michigan Department of Health and Human Services, have formed with local emergency departments, the Michigan Pharmacists Association, and Michigan Schools of Pharmacies to enhance patient care and public health outcomes as it relates to sexually transmitted infections. We will also discuss the public health impact of EPT. We will describe the state health department partnerships, and we're going to also describe how to implement EPT in additional healthcare settings, including the emergency department. So for today's presentation, we have myself, again, representing the Michigan Department of Health and Human Services. We have Dr. Farah Jalul from the Michigan Pharmacists Association. She is the Director of Professional Development and the State Pharmacy Emergency Preparedness Coordinator. After Dr. Jalul, we'll have Dr. Christine Swore, who is an emergency medicine physician, and Dr. Brandon Flores, who is an infectious disease and internal medicine clinical pharmacy specialist and pharmacy clinical coordinator. Both of them will be talking from Hurley Medical Center in Flint, Michigan. After Hurley, we'll have Dr. Jacob Mantuffel from Henry Ford Health System. He is an emergency medicine physician and the Director of Public Health in Detroit. And then we will close with Dr. Klepser, who is pharmacy or professor faculty with the College of Pharmacy at Ferris State University in Big Rapids, Michigan. For our continuing education and disclosures, they are available through CDC Train. This is a separate system from our registration. Instructions for completing evaluation and obtaining a CE will be emailed to attendees after the webinar, and the deadline for obtaining a CE is April 6, 2024. Also, we have listed the relevant financial disclosures for our speakers. As far as our pharmacy continuing education, we're going to have Dr. Jalul put in the chat a link to Learning Panda, and that is how some of our pharmacists or our pharmacists on the call will be able to obtain CEs for attending today's webinar. So first, I'm just going to cover the current state of STIs in Michigan, starting with chlamydia and its trends over time. So here in the state of Michigan, we tend to see ebbs and flows as it relates to STIs. And as you can see here with chlamydia, we had a slight rise in chlamydia cases from 2016 to 2019. And then around 2020 and 2021, just maybe due to COVID, social distancing, and the lack of people being able to test, we did see a slight dip in chlamydia cases. For our gonorrhea trends over time, we had the same upward climb during that same period of 2016 to 2019. Again, we saw the same trend with chlamydia. And then again with COVID. So in that 2021-2022 window, we saw a slight decline, largely due to the decreased amount of testing, especially within the city of Detroit. So when it comes to chlamydia and gonorrhea co-infections, we see here that 10% of chlamydia patients were diagnosed with gonorrhea, and then 27% of gonorrhea patients were diagnosed with chlamydia. That's just how the lab reports those results out. So sometimes the chlamydia results may come back before the gonorrhea results and vice versa. But the key takeaway from this slide is that co-infections are common and that the majority of people with co-infections include those between the ages of 15 to 24. And unfortunately, a third of those co-infection cases are Black women. With gonorrhea and chlamydia reinfection, on average, 14% of women with chlamydia and 12% of women with gonorrhea will be reinfected with an STI. And reinfection typically does not have anything to do with medication failure. It has more to do with the client going back and having sex with an infected partner. Younger age is associated with higher rates of chlamydia and gonorrhea reinfection as well. High rates of reinfection usually happen within 3 to 6 months of the initial treatment. And studies have shown that the risk of reinfection was lowered when people received expedited partner therapy when compared to those who just received traditional partner referral, meaning that those partners were instructed to come into the clinic for testing and treatment rather than getting expedited partner therapy from the infected patient. So to help combat reinfections, the CDC highly recommends expedited partner therapy, or EPT. And for those of you who may be unfamiliar with EPT, it is the evidence-based practice of treating sex partners that have been exposed to chlamydia, gonorrhea, and trichomoniasis. It can be given in the form of a prescription or an actual medication. Both is where the patient gives that either script or medication to their partner or partners. It can be given without a medical evaluation or clinical assessment of those partners. And here in the state of Michigan, EPT is exempt from the Michigan electronic prescription mandate. And also, just some historical context, EPT was added to the Michigan Public Health Code under Public Act 525 in 2014, if folks wanted to look up any of the language surrounding expedited partner therapy. So as a state health department, we already have processes and initiatives in place to combat ongoing and rising chlamydia and gonorrhea numbers. We partner with our local health departments and community-based organizations to conduct testing, treatment, surveillance, and reporting within the jurisdictions around the state of Michigan, as well as we have a designated gonorrhea unit that provides gonorrhea case management and partner notification. We also have our highly specialized trained disease intervention specialist workforce that go out into the community and follow up on STI and HIV cases and sexual partners. But in 2019, the CDC offered grant funding to agencies in an effort to get them to come up with more innovative strategies and interventions to help tackle STIs. So this 5-year grant opportunity names STD Peached, and PEACH stands for Prevention, Control, and Health Departments, allow STI programs to implement and build out programming that address increased surveillance, disease intervention, prevention, the promotion of CDC recommended screening, diagnosis, and some data-driven planning, analysis, and monitoring. And also included in that, within its own separate category, was expedited partner therapy. So we as a state health department, we've always promoted EPT since 2015 through provider education and awareness. But now, by it being part of our funded strategies, we knew that we had to enhance EPT. So with that, we knew that we had to actively establish partnerships and collaboratives with traditional and non-traditional partners, including health systems, pharmacies, emergency departments, urgent cares, and the Michigan Pharmacists Association. So our PEACH grant funding also led to the creation of our STI interventions unit, and we have dedicated staff that oversee these objectives from the CDC. Our unit includes myself, the Public Health Improvement Coordinator, our Public Health Liaison, our Special Populations Coordinator, our STI Provider Liaison, and our Congenital Syphilis Coordinator as well. So some of the goals relevant to EPT that we wanted to address within the work of the PEACH grant included relationship building and collaboration. So not only with our local health departments, but also again with pharmacists, primary care providers, OBGYNs, urgent care providers, and emergency department providers. There are a lot of common places. They are the common places that STI testing and treatment is taking place. And we knew that these providers needed to be aware of their ability to utilize and prescribe expedited partner therapy to increase or to decrease, reinfection rates of gonorrhea and chlamydia. So we started the work in 2020 to establish partnerships and relationships again with the Michigan Pharmacists Association, partnering with local emergency departments to expand the use of expedited partner therapy. And then we also collaborate with one of 3 Michigan School of Pharmacies. So why utilize these entities for EPT strategies and interventions? One being accessibility. So these institutions and associations serve as an accessible point of contact for individuals seeking medical assistance, including those who may have been exposed to STIs. By leveraging their reach, EPT strategies can effectively target a broader population and ensure timely intervention. Convenience. So emergency departments, urgent cares, and pharmacies are often open. They often have open extended hours and they are conveniently located in communities. This accessibility and convenience can encourage individuals to seek treatment promptly, reducing the risk or further spread of STIs. Rapid treatment. So pharmacists, urgent cares, and emergency departments can dispense medications quickly, ensuring timely treatment for both the index or infected patient and their partners. Expertise. So pharmacists and physicians alike are highly trained healthcare professionals who can provide counseling on medication use, potential side effects, and the importance of completing the prescribed treatment regimen, which just enhances the patient's understanding and adherence of treatment, contributing to better outcomes. Next generation, so partnering with Pharmacists Association and School of Pharmacies allows for education initiatives and trainings for the next generation of pharmacists, just so that they are more aware of sexual health topics and current treatment regimens. And then we knew we had to have an interdisciplinary approach or collaboration, just to help with STI management and also facilitate information sharing, improve patient care coordination, and it just helps to ensure support for those individuals affected by STIs. And then as it relates to policy advocacy, associations can advocate for policies that support the implementation and sustainability of EPT programs. So by engaging with policymakers and stakeholders, pharmacy associations can help address regulatory barriers and promote evidence-based practice in STI prevention and treatment. So each one of our speakers today are going to dive more into the projects, but I'm going to talk about each project or each relationship and what I'm responsible for. So with our EPT pilot in the emergency departments, we have partnered with both Hurley Medical Center and Henry Ford Health Center. And then from the state health department standpoint, we work together with both institutions to develop a program workflow for dispensing EPT all-inclusive kits in the emergency department. Both sites have done amazing work to provide staff training, process improvements, project enhancements, and have provided useful data for NDHHS. Some of the work that I do involves assembling the EPT medication kits. I do contract monitoring, evaluation, and of course, providing technical assistance. Since the project's implementation at both sites, so I believe we started in 2021 and 2022, the combined number of EPT kits dispensed to patients has been over 300 kits total. When it comes to Michigan Department of Health and Human Services and our relationship or partnership with the Michigan Pharmacists Association, and again, Dr. Jalul will talk more about this during her time, we have completed a number of tasks to expand the awareness of expedited partner therapy among pharmacists. Some of that work included the dispersion of a co-branded letter with Michigan's Chief Medical Executive, Dr. Bagdasharian. And then that letter was dispersed to our adolescent health providers, our local health department, our Michigan Primary Care Association, family planning partners, and our Michigan State Medical Society. I've also had the pleasure of presenting on expedited partner therapy and sexual health during the Michigan Pharmacists Association's annual conference 2 years in a row. And we've also been able to work with FARA to get some of the pharmacists CEUs as it relates to expedited partner therapy. In our partnership with Ferris State University, and Dr. Klepser will talk more about his It's Okay to Ask Sexual Health Modules and Pharmacy Survey Project. But with Ferris State, he has allowed MDHHS to lecture on infectious diseases, specifically STI and HIV, and public health to his students twice a year for the past 3 or 4 years. That lecture just explains the role of public health, STI data, and laws related to EPT. He and Dr. Farah Jalul have also helped facilitate the conversation when it came to our adolescent sexual health providers, our NPs, and our local health department nurses when the CDC changed their gonorrhea and chlamydia treatment from single dosing to multi-day dosing. So having them be a part of those conversations was extremely important, especially when the state of Michigan began to standardize its statewide EPT protocol. So our EPT Champion Coalition, because the work is always evolving, we decided to form an EPT Champion Coalition, but I often refer to us as the EPT Avengers. And here are just a few of our goals and objectives as we move forward into year 6 of the Peached Grant. So we plan to enhance public and provider-facing information. We want to recruit additional providers and pharmacists to the group. So if you are a PA, NP, pharmacist, faculty member in the state of Michigan, adolescent health provider, and you're interested in joining our sexual health EPT coalition, please let me know. But we also plan to develop EPT signage, maybe even some campaign ideas for pharmacists and providers. We want to improve communication techniques among state health departments, and we want to have providers and pharmacists across the state of Michigan continue to explore the possibilities of maybe a collaborative practice agreement, maybe pharmacist initiated EPT. But again, we know that none of this work will be done overnight. Some of this work may have to, we may have to engage in some legislative processes. But again, we want to continue this work as a team because we know that all of the disciplines involved have to collaborate in order to continue to push sexual health and EPT forward. As far as our future EPT goals within the Michigan Department of Health and Human Services, we're currently working to expand our EPT kits to urgent cares within the Detroit area, as well as within Hurley Medical Center's urgent care. We are discussing ways to expand the project with some of Henry Ford's sister hospitals. We also have been talking about the possibility that if Peached funding dries up and we don't get any beyond 2026, that we, instead of utilizing the kits, maybe going into more scripting of expedited partner therapy and bumping that up with providers and that provider education piece. We are currently in the beginning stages of brainstorming with the University of Michigan and Wayne State University School of Pharmacies. Thanks to Dr. Klepser, we've been able to leverage our relationship to be able to also have those conversations start with Michigan's other 2 schools of pharmacies, again, to maybe add that public health component, sexual health EPT lectures to their pharmacy curriculum and student organizations. And I must say that each one of the presenters here today are continuing to advance the work of EPT and sexual health. And I'm just extremely thankful and grateful for their hard work, dedication, collaboration, and their work here today on this webinar. So that's all that I have. That's my piece. And I'm going to pass it over to Dr. Jalul, again from the Michigan Pharmacists Association, followed by Dr. Swore and Dr. Fluez from Hurley Medical Center. Then we're going to have Dr. Mantuffel from Henry Ford, and lastly, Dr. Klepser from Ferris State University. So you can take it away, Dr. Jalul.
All right. Are you going to display the slides? Okay, perfect. All right. Thank you for being here. We appreciate it. Thank you for inviting me to allow me to collaborate on this and to talk about what from a state pharmacy association we can do regarding EPT and partnering up with public health. We all know that the traditional methods of partner notification and the treatment may be ineffective due to various barriers like stigma, confidentiality concerns, logistical concerns. So EPT laws were put in place to address those barriers and empower diagnosed individuals to provide treatment directly to their partners, ensuring timely intervention and reducing burden on the healthcare system. So expedited partners therapy serves as a critical strategy in public health, specifically the pivotal role of a pharmacist in its implementation, ensuring effective treatment and prevention of sexually transmitted infections. So by providing treatment to partners of individuals diagnosed with certain STIs, without a provider-patient relationship with the partner, you're breaking the chain of transmission and providing timely treatment and reducing the risk of reinfection and spread. Next slide, please. So pharmacists serve as frontline healthcare providers, and we've seen this during the public health emergency of COVID. And being frontline accessible puts us at a unique position to facilitate the implementation of EPT, which holds significant importance for several reasons. Just to name a few, accessibility. We are often the most accessible healthcare provider to a patient. You can pick up the phone and call, and you'll have a healthcare provider on the other line talking to you at any time, during the day. And so by allowing pharmacists to dispense EPT medication, access to treatment for partners of individuals diagnosed with an STI is increased. Especially for those with without a regular PCP provider. Then we have timeliness. So promoting the treatment of partners is crucial in preventing the spread of STIs and reducing the risk of reinfection. So pharmacists can provide this immediate access to EPT medications, ensuring partners receive treatment in a timely manner, even if they cannot see a healthcare provider directly. Confidentiality. Many individuals may feel uncomfortable discussing STIs with their healthcare provider or disclosing the identity of their partners. So pharmacists are trained to maintain that level of confidentiality and can dispense EPT discreetly, preserving the patient's privacy. Education and counseling. Pharmacists play a pivotal role in patient education and counseling. They provide information about STIs, safe sexual practices, and the importance of completing the prescribed treatment regimen. So pharmacists can also address any concerns or questions one might have regarding a medication, such as potential side effects and the importance of completing a full course of medication and to improve treatment outcomes and reducing risk of antibiotic resistance. And finally, public health impact. So by facilitating the dispensing of EPT medications, pharmacists contribute to the overall public health effort to control the spread of STIs. So EPT have been shown, to be effective in reducing reinfection rates. So we're ultimately leading to healthier communities. In summary, pharmacists play a crucial role in dispensing EPT medications, providing timeliness, and confidential care. And this is, if you can go to the next slide. There we go. This is why the MDHHS partners up with us. They chose to partner up with the Michigan Pharmacists Association to expand the EPT outreach and education. MPA has been working diligently with MDHHS to promote education for EPT. For example, we provide a summary of EPT guidelines. If you can go to the next slide. This is just a screenshot of one of the resources we provide and we create in-house and publicize through the MDHHS. This is a summary of clinical guidelines providing appropriate patients for EPT treatment as identified by our statute, what we can treat for, and the recommended drug regimens, what needs to be on the prescription, what informational materials need to be provided, and the patient counseling requirements, again, as identified by our state statute. Next slide, please. And so when e-prescribing, and I know Bianca touched base on it a little bit, when e-prescribing laws were put in place, there was a big concern because the law stated, effective January 2023, all prescriptions must be e-prescribed. And I think it stumped a lot of folks because there were some exemptions. And if you don't know how to read legalese, that could have been somewhat of a challenge for you. And so one of the exceptions or the exemptions under MCL 333.17754A was subsection 5K, where it exempts any prescription where a prescriber is not required to include the patient's name on the prescription itself. And it specifically referenced section 55110 of our public health code, which is our EPT legislation or statute. So it was we wanted to make sure that there was no interruption in EPT. So we partnered up together, and I have a screenshot on the next slide of the letter that was created by the department's chief medical executive and myself. We authored a Dear Provider letter that was sent out to all providers dictating that EPT practices will not be affected by the statute change. So this is a very important collaboration between our our MPA, our Michigan Pharmacists Association, and our MDHHS. And then we even, if on the next slide, which you also showed a brief highlight of that, Bianca, it's a sample EPT prescription that we created that could be adapted to fit the needs of the healthcare system that you work for or the clinic to utilize as a written or a paper prescription for EPT. So we included what needs to be on it based on our Michigan statute, including expedited partner therapy or EPT for the name if it's not available, or if the patient that is being treated does not want to disclose it. The date of birth, which if you don't have the date of birth of the patient, we use an example, January 1st. So the date, January 1st, and then the year that you're in. This was created in 2023, hence why it says 2023. And then the template script also had the treatment regimens per state guidance. So it's a simple check mark on there or circle, and then you sign it, and that's pretty much it. So we are trying to make it as easy as possible for folks to utilize this EPT prescription and methodology within Michigan. And it just partnering up has been a true great resource because I think it just shows that pharmacists are working with our public health individuals to make sure that our patients and Michiganders are adequately treated. And that completes my portion of my presentation. And then I'm going to turf it over to Dr. Swart and Flus.
Good afternoon. Hi, my name is Kristen Swar. I am an emergency physician at Hurley Hospital in Flint, Michigan. I work with Dr. Flus, our pharmacist, and we are going to talk a little bit about the nuts and bolts of having implemented an EPT program within our emergency department. We also have the advantage of having EPT kits in which our patients whose partners are prescribed EPT can go home with all of the prescriptions as well as all of the prescriptions in hand as well as educational information. And we'll talk a little bit about Hurley specifically and our implementation of this, our barriers, and other parts of our community. We do not have any relevant financial disclosures. So briefly, this has already been covered, but expedited partner therapy is the sexual partners of patients with STIs receiving treatment, being able to leapfrog some of the main barriers to care, some of which include stigma, as well as in some communities, both the cost and the time of obtaining timely medical care. I believe that Bianca has covered this well, but expedited partner therapy is the practice of treating sex partners of patients diagnosed with chlamydia or gonorrhea by providing the prescriptions or the medications to the patient's partner without actually having to examine or form a face-to-face clinical relationship with the patient. This can be done through medication distribution or through prescriptions, and it has been found to be safe and effective when there are barriers to partners accessing health care. May I have the next slide, please? As many of you know, the emergency department is oftentimes the access point for people with limitations in their access to healthcare, and also for people who have complaints that may be related to sexual health, whether or not they know it at the time of presentation. Hurley Medical Center has a partnership with Michigan Department of Health and Human Services to distribute these all-inclusive medication packets to our partners via the patient. You can see below some sample kits. You can see that they include the medications on the right, as well as a letter from the Michigan Department of Health and Human Services, and some pretty cool QR codes that allow the patient or the patient's partner to scan those and receive some video information in a more modern and user-friendly format about STIs and sexual health, as well as disease prevention. I can take the next slide. We are a 443-bed academic medical center located in Flint, Michigan. We are a high-volume level 1 adult and level 2 pediatric trauma center. Within our catchment, the rate of STIs most recently available in 2020 is 686 per 100,000. This includes gonorrhea, chlamydia, and syphilis. As you all know, there's been a recent rise in the past several years of syphilis, so this number has increased. Within our catchment area, the per capita income is under $18,000. This can lead to many barriers in effective partner treatment and access to care, as well as education. And as those of you who are familiar with the emergency department or work in one know, visits for STI-related complaints or complaints that end up being STI-related after appropriate assessment and examination are very common in the emergency department. Expedited partner therapy is definitely legal in almost all states and provinces within the US. There are several in which the law isn't particularly clear, but does not explicitly prohibit expedited partner therapy. So as I'm going through this information, I encourage you, if you are not within Michigan, to check your local laws and see if you're able to provide this therapy as well. This is a brief excerpt from the Public Act 525 that allows Michigan providers to dispense expedited partner therapy for chlamydia, trichomoniasis, and gonorrhea whenever appropriate. As you know, 20 to 30% of medication prescriptions are never filled. These are or in this case, now that we have e-prescribing picked up. Even people who have chronic diseases, about 50% of those medications are either not taken or aren't taken as prescribed. And this cost, as it relates to healthcare, costs hundreds of billions of dollars to the US healthcare system annually. So Dr. Flues, our pharmacist at Hurley Hospital, is going to talk a little bit about our implementation and Epic workflow that allowed our emergency physicians to seamlessly provide expedited partner therapy without extra work, and giving them the tools that they needed to allow patients to receive access to this service. Thank you very much.
All right, thanks, Dr. Swar. Bianca reached out to us in early 2021. So we've been providing this service since about July of 2021 for expedited partner therapy in the emergency department. And one of the important things for us was to try to integrate it in our typical workflows that we did in the ER. So, working with Dr. Swar and the other ED physicians and advanced practice providers, we tried to figure out the best way to do so. And what we figured was the quick lists are what we typically order off of in the ER. So this was a good place for us to start. So as you can see in the highlighted red box, we have a panel with STD medications and expedited partner therapy that are included together. And that way, if a ED provider is ordering an STI medication for a patient that's in-house, they're already prompted and thinking about expedited partner therapy for the patient to go home with. So that, you can go to the next slide. So this is what that looks like when it's clicked on. It could also be searched for outside of the quick list as well if someone else was going to order it. But we have the partner therapy kits included at the bottom of the typical STD medications that we built in this order set for them. Next slide. So this is what the first one looks like. This is the standard sulfixime and doxycycline kit. The one thing that we built in to make sure we're asking all the right questions and doing everything is that the patient is provided any known allergy history for the partner, and there's no relevant allergies. So we have an acknowledgement statement inside of the order just to make sure that was asked. And we can provide kits for any partners in the last 60 days. So they can just choose, whether they want one kit, 2 kits, or free text in if any more than the buttons available. Next slide. And we have also the pregnant partner kit. So the first slide of this is asking if the partner is known to be pregnant or may be pregnant. And if selected no, the next slide goes to a next cascaded question. If you want to move on to the next slide. If the patient has an allergy to a tetracycline antibiotic. So it's trying to steer to the preferred regimen of sulfixime and doxycycline, but we still have this available as well. We find that, at least in our community, that most of the ones that we give out are the standard sulfixime and doxy, and most of our patients that are pregnant have good follow-up with their OB and generally get expedited partner therapy out of their OB office. Next slide. And we've shown before, these are what the kits look like. There's some educational information on the outside, the QR codes on the outside, and the right side of the picture shows the doxy bottle, the sulfixime kit, and additional information for the patient to go home with and give to their partners. Next slide. So a few things that we found that were a little bit of operational challenges as we got up and going is, EPT kit and labeling workflow. So most of our inpatient labels aren't meant for, to go home with. So, Michigan law, you have to have, all of the elements of a, prescription label if you're going to dispense this out of the ER. So we made sure that, our label met all the regulatory requirements. So we have, Hurley Medical Center Pharmacy, the address, an order number, the name, and a date of birth with the first of the current year, which this picture is 2021, and then quantity dispensed and a provider. So making sure we met all those labeling requirements, because most of our inpatient labels might not have all of those components onto it. Education. So we did education for the ER provider groups and advanced practice providers when we started going. And every quarter or a few times a year, we re-educate on expedited partner therapy in the emergency medicine meetings and give some updates and friendly reminders that these are available. And like we already kind of mentioned, leveraging the electronic health record. So we have these order questions built into the orders to help make sure we're asking all the right questions and meeting the requirements for dispensing EPT. Next slide. So just a little bit of the results. So since July of 2021, 188 patients have received 216 EPT kits since we've launched in July 2021. And this may be a little bit difficult to see, but it breaks down the orders quarterly. So we're typically between 15 to 25 EPT orders per quarter. And there's some ebbs and flows, with kind of going up and down depending on, sometimes around holiday seasons, we see a spike up, or, college students coming home from, winter break, spring break. So we do see that. And then as we re-educate in the ER at staff meetings, we generally see some upticks after reminders and re-educations. So we have some demographic data on the index patient, not necessarily the who's receiving the kits, but typically it's about 2/3 of the patients that come in as the index patient identifies female, and about 1/3 identifies male. So our breakdown on the index patient for race, so about 80% identify as Black or African American, and then white or Caucasian, 19%, and a few percent Hispanic or 2 or more of the above. So definitely representative of our community, and health disparities in our area, making sure that we're providing these patients kits to go home with. Breakdown on age. So most patients are 18 to 29, about half of them, and then 10% less than 18, 27% 30 to 39, and then the remaining 10% is 40 to 49 and 50 and older. So typically who we see come in for the index patient. I like this slide. It's a little bit maybe busy, but it's just shows de-identified our ordering provider breakdown. So I think it speaks to the ease of the workflow that 81 different unique providers have been able to order expedited partner therapy for patients that leave the ER. So, we have as high as 17, and then, we have listed out kind of de-identified up to, 3 kits, and then we have 76 that are, 1 or 2 kits for ordering providers. So definitely easy to use and administer and prescribe for patients. So next steps would be expanding EPT more into our urgent care. So we have some workflow set up for our on-site urgent care. Might not have seen too much of an uptick yet, so maybe some re-education. And then we've had some interest from our clinics as well. But our OB clinic does a good job with writing EPT prescriptions. So they order a lot of those through prescription, and we've got some interest from other clinics as well. And considering more real-time testing, so most of the patients that we're sending out with kits is presumptive therapy, because we don't have the results back yet. So getting more real-time results, and being a good resource stewardship, antibiotic stewardship initiative. Next slide. So to conclude, expedited partner therapy is safe, effective, and eliminates barriers for patients to have access to care who might not otherwise seek it. Non-adherence is associated with high rates of hospital readmission or admission, suboptimal patient outcomes, and increased costs. And what we've learned is, with most projects that are more education-based, it has a short half-life and generally regresses back to prior to the education intervention. So using that in addition to system-based interventions in the EHR, really helps sustain the intervention. All right, thank you, and I'll hand it over to Dr. Manteuffel to show us what they're doing at Henry Ford. All right, thank you.
Yeah, thank you, Dr. Flewis. Can you hear me okay? Okay, excellent. So yeah, some great ideas there. And, I'd have to credit Dr. Swar and some of the colleagues over at University of Michigan, along with Bianca, for helping us get started with all of this. And it's really interesting to see what you all have done, and frankly, going to steal some of your ideas because they're very good. Especially, I like the addition to the EPIC order set there. So I'll get into my material. I'll try not to be redundant. Can you go to the next slide, please? No financial disclosures related to this material. Next, please. So again, not to beat a dead horse, but one of the things I haven't heard mentioned is that 50 to 90% of the chlamydia and gonorrhea infections are asymptomatic, and that's particularly problematic in Detroit. I view this as a major health disparity that we see. There's a lot of inequity in terms of ability to get to clinics and to get treatment, and so that's one of the selling points I've used in order to get buy-in from our both leadership and our clinicians. Next slide, please. So essentially, we are trying to break the cycle of infection, particularly in underserved communities like Flint and Detroit as well, and overall improve public health. So I don't have my pharmacy counterpart here today. She's moved on to a new position, but she was Nancy McDonald. For those of you that might know her name or worked with her in the past, she's amazing. And she was a huge part of getting our program up and running at Henry Ford. But it all started with we have a public health committee in our Department of Emergency Medicine. This idea was brought forth and kicked around a little bit and then pushed on again. And then Bianca came along and, we it reaffirmed our desire to do this and to figure out the logistics of doing expedited partner therapy from the ER. And as I mentioned, huge collaboration with pharmacy. They attend all of our public health committee meetings, so that makes it helpful to have them on board from day one. As I know, this is particularly strongly attended by pharmacists, and you guys are really good at following the rules and doing things in a compliant fashion, where I just like to get things done. And so my pharmacists help kind of pull the reins on me and make sure we're doing everything correctly. And I'm very thankful for that. There's a lot of compliance factors, giving any medication in hand from the ED, including the labeling that Dr. Flewis mentioned. And also they're in charge. We have a in ED pharmacy, so they're doing the stocking and the inventory. They help develop our policy. We have a tier 1 across the entire health system policy related to EPT and how we are supportive of that and who would be indicated for and how to execute. Also, the EPIC related changes, we use EPIC as well. It was very much undertaken by our pharmacy group. And then lastly, the prescription component of it. At some point in the future, we won't have EPT kits like are provided now. And so we're hoping that once this becomes ingrained in our practitioners, that ordering the prescription is the next logical step. And it's just something that we do naturally. Next, please. So this is a slide that it's MDHHS slide. I don't know if it's a little hard to read or not, but this is comparing Detroit to the next highest jurisdiction, which I think is significant. We almost double the Kalamazoo County, I think is the next highest jurisdiction from gonorrhea and chlamydia case rate per 100,000. And so, when we look at health disparities, this is how I get my clinicians to buy in. Our patients are behind the 8 ball here. That these infections are in their community, and we should be doing everything we can to try to lower these infection rates and stop the cycle of reinfection. So we started getting our EPT kits in January 2022. Took us a while for us to build out our EMR component of that. We did our education for all the staff, docs, PAs, residents, and the nurses as well. And as I mentioned, kind of emphasizing the health disparities and the opportunity for improvement in patient care. Next, please. So we started before we had our electronic ordering by using a paper form just located in the pharmacy for the EPT kits, but switched over to electronic ordering in June of 2022. And essentially, this was a pop-up that came up that kind of pre-selects to order one or the other, the pregnant partner kit or the non-pregnant partner kit. And of course, accept is pre-selected to make it easier. This pop-up was triggered by a list of over 1,600 STI-related ICD-10 codes, and if the provider was selecting a disposition of discharge home, then this would pop up to remind the clinician to consider ordering EPT. And we had to make a slight tweak shortly after starting this. Bacterial vaginosis was an ICD-10 code that slipped in there and was causing some false positive or false firing of the BPA, or best practice alert is what we call it. And so we stripped those out, and go to the next slide, please. This is what it would look like, if there was, like I said, 1,600 of these ICD-10 codes that would potentially trigger the pop-up. And next slide. And if you selected discharge home, then you got the reminder. So that's how we have it in our workflow. You can just order it, but like I said, it's actually not part of our quick list the way that the Hurley folks have done it. So like I said, I think that's a great idea and probably another way to potentially increase the number of kits that we give out. Next, please. So similar to their order, we built in the hard stop for allergies. We can get up to 10 kits per our order that has been built, and our record is 3 so far. Next slide. We also use an EPT dot phrase. I'm not sure how many of our clinicians use it, but some like to document it as much as possible. And if they're doing something that would be what they consider outside of what their usual care is, this is a nice way to succinctly or put in a short dot phrase .ept and have all the relevant information, including the laws, like imported into the provider note. Next, please. So essentially, the way our workflow happens is we see the patient, there's a concern for STI, we make a shared decision-making for empiric treatment and recommend the partner be treated. And, as an ER doc, from my training, it's always been your patient's not treated until your partner's treated. And, I would always say, no sex for 7 days until both you and your partner are treated. And so I think this can be a natural way to re-enter our thought process, especially in the period of EPT, to be providing this to all of our patients. And if you don't, you haven't treated the patient because you haven't treated their partner. And of course, EPT is indicated if the patient is unwilling or unlikely to be treated. But I don't know if you've been to an urban ED and seen the triage wait times or the boarding crisis that we have. It's an issue, and those are definitely barriers to patients being seen and treated. So if the patient's eligible and they have partners within the partners within the 60-day time period, the patient's offered EPT and the clinician orders the kit, and the nurse will deliver the kit and the provider gives guidance on the kit contents. Next slide, please. So some results for us in their first year, from January to December 2022, we gave out 67 kits to 58 unique patients. Before we started our electronic reminder in June 2022, we were giving out 0.1 kits per day, essentially, and then almost tripled that after the reminder came in. So that was helpful. Our rate of BPA prompting EPT kits was 5.6. So we set a goal of 10%, just understanding that not all patients are going to want to give their partners EPT, or there might be some reasons why it's not indicated. And so we were shooting for a goal of 10%, and we hit that doing some continuing education and data review from September 2023. Showed our kit rate was 10.8%, so 12 kits out of the 111 reminders that fired. And we took a deeper dive into that. Yep, thank you. Into that September caseload, and to see specifically when EPT was not given, why was it not given? So we looked at, did a thorough case review on 30 cases where EPT was not given, but the BPA fired. And what we found is that EPT was probably indicated in 18 of those 30 cases. And in those cases, the patient was empirically treated, but there was no documentation of EPT in 16 of the 18 cases. And then in 2 of those cases, the patient actually declined to provide EPT, and that was documented by the provider. So, nothing you can do in those cases. But the other cases, I think there's some room for improvement because I understand that not all patients are going to want to give their partners EPT, or they're not going to want to have that conversation. But we as the providers can say, EPT offered, patient declined. And I think that would suffice for what I would like to see in a chart review. And of the 12 other cases where we determined that EPT was not indicated. And so in 6 of those, there was low suspicion for STI. I'm not exactly sure what diagnosis in those cases triggered the pop-up, but the patient was not empirically treated. So you could argue that EPT was not indicated in those cases. And 3 of those cases, the patient was co-infected with another STI. So EPT is specifically for gonorrhea, chlamydia, and trichomonas. So herpes, syphilis was on our ICD-10 code list, and we've since taken some of those strictly gonorrhea, chlamydia, and trichomonas diseases and ICD-10 codes off the list. And in 3 of those cases, the patient was already treated, and the patient was actually in the ED because they were told that they were exposed to an STI. So, not all of the 30 cases should have had EPT. I would argue that, 16 of those, though, were definitely opportunities for improvement. So the take-home points from that review were to increase clinician education on EPT and at least encourage documentation as to why EPT was not given. And then we reprogrammed our BPA right around December to take out the non-GC chlamydia and trichomonas diagnoses, so it's not firing the false positives. And then we'll go back and look at the data again and see what our kit rate per pop-up is. Next slide. That's a big deal when it comes to having pop-ups. They're universally disliked by clinicians, including myself. The more pop-ups, the worse. And so if we can make more of those pop-ups meaningful, that they won't be as ignored going forward. So as I mentioned, we refined our ICD-10 code list, and we actually identified a few providers that routinely, are not giving EPT, and so that gives like an opportunity for provider level feedback on missed opportunities, or maybe they're offering it but they're just not documenting it. So the overall goal for us is really to raise the standard of care to the level that not providing EPT triggers an internal QA review. So we do QA for lots of different things. So you gave the wrong antibiotic, or the patient returned to the ED within 72 hours. And in my opinion, if we have the means to provide something to the patient, and we're not doing it and not documenting why, then I think that's something we can look at again. So as I mentioned, in treating STI, you have not treated the completed treatment until you've also addressed treating the partner. And next slide. So yeah, this just shows our graphic results of kits given. So overall, 177 kits to 159 unique patients. We have had the ups and downs just like Hurley, but I feel like that re-education is key, and we do that periodically, if not bi-yearly, quarterly to bi-yearly. Every time a new intern class comes in, I make sure they're aware of it, and more and more education, just reminders to elevate the standard of care. Next slide. So additionally, much like Hurley, we've had 72 unique clinicians order. So it's not just me doing this, although I might have one of the higher ordering rates. And also we looked at, of the kits given, how many of those patients actually tested positive for an STI. So gonorrhea, chlamydia, or trick. And so we actually, at least one of those popped up on 57% of our cases. So it makes me feel a little bit better about the antibiotic stewardship, but I share the concerns and the desire for real-time PCR, gonorrhea, chlamydia, and trichomonas testing. The technology is there, the capability is there, and it's just a matter of, I think, making the case to leadership, and it will require decentralizing some lab resources and things like that. But I think this is something that we can do for our patients to improve care, antibiotic stewardship, and the like. Next slide. So lastly, just continuing the education, as I mentioned, raising the standard of care, and using EPT prescriptions where kits are not available. So this was a system-wide policy, but we only have the kits at our main campus. Problem I have, and if somebody knows how to do this better, is how to track prescriptions in Epic. It can be pretty hard to pull that kind of data, and I've not gotten good at it yet. And I'm curious to know if across the system, if anyone else is using prescriptions. Probably not, probably because it's not in the face as it is, like I am with our clinicians here, and reminding them that this is something that we should be doing. And again, working towards the real-time PCR testing for STI. And thank you very much.
All right, well, thank you very much. I guess I'm bringing us home. I'm Dr. Michael Klepser. I'm a professor of pharmacy at Ferris State University, and I want to talk a little bit about the importance of partnerships with public health and academia. Next slide, please. And there's a number of ways that we in academia can partner with our public health colleagues. And what I found over the years is really there's four big areas that we have come together and provided a lot of synergy regarding some of these mutual beneficial areas, including things on research, development of needs assessment, messaging, and completing different initiatives. Next slide, please. With respect to research, we've worked with public health in a number of areas, both on a statewide basis and in a county-specific area. One of the things that we did is we worked with Kent County and Ottawa counties to look at the knowledge of university students in those counties related to sexual health and their understanding of expedited partner therapy, barriers to therapy, and so forth. And the data from this initial study was presented at the American Public Health Association meeting this past fall. And some of the updated data will be presented at the HIV/STI conference in Kalamazoo later this summer. There were 254 surveys that were completed, and we had pharmacy students work with public health and university officials to develop these surveys and validate them. From the data, the original reason we started to do this project is because we had data in Kent County that suggested that college-age students were a major target for initiatives related to sexually transmitted infections in education. But we pushed back, and we did not know if that was really the college students or the individuals of that age that were not currently enrolled at a university. So we wanted to double check to make sure that we were targeting the right population. And from the data, we found that 87% of students knew how to initiate conversations related to STI prevention. Yet only 57% of students reported regularly using condoms. 69% of students or respondents reported speaking to their partners about sexually transmitted infections. However, a number of students also noted that barriers to initiating these conversations was frequent. About 8.5% of students reported having ever been diagnosed with an STI. However, 68% of individuals admitted knowing that they did not know how often they should be screened. And the top reasons that these individuals weren't screened for sexually transmitted infections is they didn't feel it was necessary. They didn't want to use their parents' insurance. They were embarrassed, didn't know where to get tested, and were afraid of what other people would think. Next slide, please. Also related to that, information, the college-age students, there was not a large understanding of expedited partner therapy. In fact, the majority of individuals had never heard of expedited partner therapy. We also then worked with Bianca on this project in the Michigan Pharmacists Association, where we had students develop a survey because we knew that pharmacists were going to be frontline in counseling and interacting with patients related to sexual health and sexually transmitted infections. However, we really didn't know much about how comfortable pharmacists and student pharmacists felt about counseling on these topics, or we didn't really know how much knowledge they had about these areas. So we did a survey of student pharmacists and pharmacists in the state of Michigan. Again, this was presented at the American Public Health Association meeting last fall. In this survey, there were 236 surveys that were completed. And when asked to rate their counseling comfortability on a scale of 1 to 10, with 10 being the least comfortable, or 1 being the least comfortable, and 10 being the most, interestingly, respondents felt most comfortable counseling on condom use and least comfortable talking about pre-exposure prophylaxis. Also, when asked to rate their comfortability on patients who is identifying as lesbian, gay, bisexual, and or queer questioning, their comfortability was unfortunately about a 7.2, and transgender about 6.3. So they did not feel comfortable discussing these topics with individuals that were, perhaps different from them. Again, unfortunately, we found that there was a large segment of the population that did not have a good understanding treatment modalities such as HIV PrEP and EPT. Next slide, please. So with some of these data, we worked with MDHHS to figure out, okay, what do we need to do to improve these findings or tackle these findings? And using some of the data, we decided that there were needs to increase education and awareness of sexual health topics, including EPT on college campuses, and that there needed to be an increased education so the comfort surrounding sexual health topics among pharmacists and student pharmacists was improved. Next slide. So then we worked with MDHHS and public health to develop messaging schemes related to these topics. And to do this, one of the things, as Bianca has mentioned, we worked with MDHHS and the Michigan Pharmacists Association to come together and bring Bianca to the Michigan Pharmacists Association education or annual meeting to talk about expedited partner therapies and sexually transmitted infections. Also, in those programs, we also talked about communication strategies with patients. One of the things that we determined is we needed to demystify and destigmatize topics related to sexual health. And so we, along again with MPA and with MDHHS, we received a grant to develop a educational program called It's Okay to Ask. And this is a 6-module program that we're developing that's going to be multimedia and interactive to increase knowledge of and comfort of pharmacists and student pharmacists in discussing sexual health topics. We've also worked with Bianca to engage the other colleges of pharmacy in the state to increase sexual education experiences related to sexual health. And we've developed in Kent County and Ottawa County a plan to develop a summit to bring together leaders from the various university campuses in Grand Rapids and in Kent County and Ottawa counties to help identify ways to educate students on sexual health topics and expedited partner therapy. Next slide. With respect to assisting MDHHS in completing the initiatives, again, we've opened up our doors to Bianca and her colleagues to come into the college to provide lectures on sexually transmitted infections to our students, both in public health electives and in infectious diseases electives. And again, we've also helped cultivate relationships and contacts for MDHHS at other universities and colleges of pharmacies, because we just realized what a valuable resource public health has been to us and to our students. Also, to help MDHHS accomplish its goals, we've helped them gain access to pharmacy practitioners through the assistance in doing research and presenting data, as well as giving continuing education programs to pharmacists. From Ferris's standpoint, MDHHS has helped us because we've been able to recruit students to conduct research projects and develop these programs and present their data at local meetings and publish manuscripts. And for our students, these are really extremely valuable, for them as they go out seeking residencies and fellowships. And it's also valuable from the standpoint of we're adding this important information back to the body of literature. So it truly has been a mutually beneficial and synergistic relationship that we've established. Next slide.
All right, thank you so much, Dr. Klepser. We are now going to open up the floor for questions. So we're gonna do somewhat of a panel discussion. I wish I could see you all, but I can't. I could just see my PowerPoint. So we're gonna have Malaysia kick us off with our first question for all of us who presented today. And then that will allow folks in the chat to be able to type in their questions. If you have questions about our approach for EPT from a state health department level. If you have questions about the EPT kits and how we're able to do that within the emergency departments. And then also if you have any questions for our partners over at Ferris or the Michigan Pharmacists Association, we implore you to use the chat. And Malaysia will also monitor the chat, and then she'll kick us off with our first question here in our panel discussion.
Thank you, Bianca, and good afternoon, everyone. Thank you to our presenters today. And the first question that we have is, how can state health departments support emergency departments and pharmacies in creating standardized guidelines for EPT, fostering consistency and efficiency?
So I think that question, I wrote it for me, I guess. Definitely when we first started this project, it hadn't existed from what we had known. When I got into this position, I had done my research and my due diligence trying to find out, is someone already doing the work, right? So that it would just make my life easier. But it did not. I did not see any research that had been established to where this particular project was being implemented in tandem with a state health department. So working with our emergency departments like Dr. Mantuffel and Dr. Flus and Dr. Swore stated, we learned a lot from each other in terms of our challenges and what facilitated these projects. It is not, I wouldn't say, I mean, it's a wonderful project. I wouldn't say that it doesn't have its snafus, but the more that we learn, the more that we can share our challenges with other facilities so that they can work out kinks, and then the project can be established. Just like Dr. Mantuffel mentioned, we did have a shortage. I don't think we covered it, but there was a shortage of Sufixing back in, I believe, 2021 or 2022, where we had to switch over to prescribing. So that was something that we had to also overcome when there was a pharmacy shortage of medication. So just continuing to work together. We have our quarterly check-in meetings. So in addition to giving them kits, we check in with one another. Like I said, we go over process improvement, quality improvement. How can we make this project better so that when we go to other emergency departments or we're presenting on this, we are presenting the best information that's relevant so people can take these projects on potentially at their emergency departments. And I don't know if Dr. Flus or Dr. Swore or Dr. Mantuffel want to chime in as well.
I think you're spot on and covered it great.
Agree. I don't have anything to add to that one.
Yep.
I do see some questions in the chat. I don't know if we want to look at those.
Yep. So the next question is, how are local pharmacies reimbursed for these medications?
So as far as expedited partner therapy goes, the person who is obtaining, so that partner that has a medication prescription for EPT, they're covered if they have their own standard insurance. Their insurance is supposed to cover for an EPT. If that partner goes into the pharmacy and they do not have any insurance, they do have the ability to pay for the medication out of pocket. The three medications that we use, be it Sufixing, Doxy, and azithromycin, are supposed to be relatively cheap, but we know that prices do vary based on a community-based pharmacy or a big chain pharmacy. So that is how it works with expedited partner therapy. If folks are unable to afford the EPT medications when they get into the pharmacy, we are also working with FARA to make sure that pharmacists are able to, and even Dr. Klepser, when we're raising up that new generation of pharmacists, to make sure that they are included in their language. You can go to the local health department. The majority of our local health departments in the state of Michigan that we provide STI funding for will give that partner medication for free to no cost. When it comes to our project in particular, where the state health department is supplying these emergency departments with medication, that funding comes from the CDC. That funding comes from that STD Peach grant that we talked about. So that is how we're able to supplement the medications for the emergency departments.
All right, thank you. So this question is for Dr. Klepser. What does CAPE Charm stand for?
So CAPE stands for the Collaboration to Advance Pharmacy Enterprises, which, honestly goes well beyond pharmacy, but it was a cute little acronym. And CHARM stands for the Collaboration to Harmonize Antimicrobial Registry Measures. And CHARM is a project that we're funded by the state. And their mandate for us is to track outpatient antibiotic use in the state of Michigan in emergency rooms, urgent cares, and outpatient clinics. And we create interactive dashboards for each of our partners to assist them to track antibiotic utilization patterns, as well as concordance with practice guidelines. These data are granular and can get right down to the prescriber and patient level, as well as breaking up by a variety of disease states. The other thing that we've done is we've been asked to create a statewide dashboard of anonymized data that we provide to our partners so they can use those dashboards for benchmarking. And I believe of the participants involved, I know that Hurley and Henry Ford are both participants in CHARM.
Okay, thank you. The next question is, can you go over the procedure for obtaining ACPE credits for pharmacists through Lecture Panda for this program? I don't know if that's a New York question.
Yeah,
So actually,
go ahead.
I was just going to say, thanks, Farah. So an email is going to be sent out to all of the participants today that will contain specific and detailed information on how you can access those credits.
Okay, thank you. The next question is, if a patient has multiple partners, is there a limit to how many kits they can have? Are kits in the ER pre-made in the pharmacy and assembled and sent to the ER to be distributed, or is this something practitioners are putting together in the ER?
I think Dr. Flus and I can take this, and he can go over exactly the packaging, but in our hospital, these are pre-prepared. In answer to your question about a limited number of EPT kits, our order set allows you to hot button order 1 or 2, or to free text in anything. And we encourage our providers to ask how many partners the patient has had in the last 60 days, and that is the limit. One of the ways that that EPT with us has become so successful is that among the providers, we enjoy competing to see how many kits we can dispense at one time. And I think the current record for appropriate dispensation has been either 5 or 6 kits to someone who was able to then provide treatment for all of their partners within the past 60 days. We don't limit that in any way.
Yeah, I think 5 was the most that we've had so far. But the kits all come from Bianca at MDHHS. So the pharmacies in the hospital aren't putting together the kits. They're coming prepackaged from MDHHS, which I believe contracts out with a pharmacy to help with putting those together for us. And there's some flexibility and customization on the educational material, and we chose to have condoms included and what we have in the kit, but all those are prepared in advance.
Mm-hmm. Yep, just like Dr. Flus and Dr. Swore stated. In the state of Michigan, with our EPT law, there is no limit to the amount of prescriptions and the amount of kits that can be provided. And the same goes for both of our emergency departments. If they need, if they don't have the kits on hand because somebody requested 20 some odd kits, then they are more than able to again do that prescribing. Again, as the state health department, we do work with a pharmacy and a repackager. And what the repackager does is they put the dosages in that individual or single dose that we need for each packet. So I get the medication, I hand put everything in there, the condoms, the lube, the medications. I do medication labels for the pharmacy folks, so they'll see the expiration date, they'll see the lot numbers for the medications, and the QR code and everything like that. So it is already ready to go by the time it gets to them, and then they do their quality control checks to make sure that the medication that I say is in there is truly in there. And that's how we kind of check each other when it comes to those kits as well.
And the workflow to dispense an EPT kit in the emergency department is the same as the workflow for ordering any medication. So once it's placed in the EMR, we receive it from pharmacy, and it comes through the same tubing system or on the same pharmacy system as we do any medication. So there's no new or additional workflow for nursing staff or for anyone else who's obtaining medications to learn or to practice.
Thank you.
Okay. So there's a comment here. It says independent pharmacies will have to be reimbursed for the cost of EPT. I see a barrier that needs to be addressed. Challenge for patients to pay for EPT.
So that is the first time that I'm hearing about independent pharmacies having to be reimbursed for EPT. Farah or Dr. Klepser, is that something that's being done in Michigan, or I had never heard that independent pharmacies will have to be reimbursed for EPT.
So from my understanding is the way that you get reimbursed for the actual drug is either if you bill through insurance, and if you have to have the patient's name and date of birth for you to do that and insurance information, or it's an out-of-pocket cost. So somebody is paying for it essentially. And maybe we're kind of reading just the drug portion versus the counseling portion. I think that's they might be referencing to. But regarding the actual medication, it's either the patient or out of pocket. I don't know if Dr. Klepser, you want to add to that?
No,
I think
just to clarify, when you're talking about the reimbursement, that's not for the index case patient. That is for the individual for whom the prescription is going to be given. Is that correct, Farah? So there has to be that engagement with the individual who's going to be receiving expedited partner therapy, and they would likely have to bring in the prescription at that point in time. Or the individual who is the index case could fill a prescription, pay for the medication by cash, and then provide it to the partner.
I hope that answers the question.
Okay. Next question is from another independent pharmacy. It says, representing independent pharmacy practice here, most of EPT direction seems to originate from the ER health systems, directly where patients will prevent for testing, or maybe present for testing. Are testing and prescriptions for EPT offered by county health departments in Michigan? If so, are there any barriers to providing this medication by the county health providers that community pharmacies may be able to help provide? Is there a way that we can get involved in helping treat these patients once identified?
So from a health county or health department standpoint, a lot of our health departments, especially our high morbidity health departments in the state of Michigan, they are 340B eligible, or they're able to receive 340B medicines. So a lot of our health departments do give out, or they are able to give out expedited partner therapy, the actual medication, and they are able to do prescribing because a lot of them have medical directors or health officers that will allow for that signage of EPT medicines. I did not remember the rest of the question. It was here on my screen. Malaysia, you mind reading that second part again?
So while she's looking for that, Bianca, one thing to bring up is that under a collaborative practice agreement, if a pharmacy, worked with a provider and had the authority, they could provide EPT scripts to patients that were coming to get prescriptions filled for sexually transmitted infections for themselves, Additionally, I know there are some pilot projects underway in the state where pharmacists are using CLIA point of care tests for sexually transmitted infections. And again, working under a collaborative practice agreement to provide therapy out of pharmacies. I know there's at least one pharmacy in the Detroit metro area that's, engaged in a project, such as that. And that was funded actually by the National Association for County and City Health Officials. And so it's looking to expand access to care in pharmacies that way as well.
Mhm. Mhm.
Okay, I found the question. I believe the last question that's in here is there a way that we can get involved in helping treat these patients once identified?
From a pharmacy level.
So Bianca, I think,
Go ahead.
again, for that expedited partner therapy, again, collaborative practice agreements,
Mhm.
directing individuals to health departments or other sites where individuals might have access to EPT, and also just having information about expedited partner therapy, available, posted or brochures, just telling what it is, so individuals potentially can kind of keep that in mind as well, if they know that they're at high risk for a sexually transmitted infection.
Absolutely. Absolutely. We advocate for our local health departments, folks, if they are able to see their primary care doctor, urgent care, ED. We always, point them in that direction, especially for testing and treatment as well. So yes, thank you, Dr. Klapser.
Okay. Do we have time for more questions?
Yeah, we got about 2 more minutes, so probably one more question.
Okay. Hi, I want to applaud you for the great work you've done with the EPT kits. I'm one of the emergency department pharmacists in Muskegon, and as you know, we have relatively high prevalence of STIs. Are there any plans to expand the EPT kit program?
Absolutely. So in our grant, we wrote it up to where we wanted these kits to be in emergency departments, urgent cares, and FQHCs. So if you are part of these high prevalent STI morbidity jurisdictions and you are interested in getting provider education or even interested in these kits, please reach out to me. Let me go to our next slide here, where this is all of our information. So again, if you're interested in the kits, or if you want to have a conversation about maybe how to better do your workflow as it relates to partner therapies, please feel free to reach out to myself or anyone else here on today's panel, because we want people to know that EPT is a tool, it is a resource, and it is something that definitely helps decrease reinfections, and it just helps across the board as it relates to STI prevalence. So again, please, I implore you to reach out for sure. And I believe, let me see, I wish I could see everybody. I do appreciate everyone for taking the time out today, spending some time with us, learning about expedited partner therapy and how we've been able to implement it within these 3 different entities. Again, this is our contact information. I believe that this session is being recorded and will be sent out. And you all are also free to have our slides as well. Again, thank you to all of our panelists, all of our presenters today. They are an absolute joy to work with. I hope they never get tired of me, but they are doing that heavy lifting for expedited partner therapy within their respective disciplines. And I am so grateful for our partnerships and our collaboration and being able to speak with you all today. So thank you very much. And I hope you all enjoy the rest of your day.